Hello, it's great to see all of you here. And these posters, even just walking through very quickly in a couple of minutes, are simply amazing. And I look out at that and I think to myself, you know, the future of medicine is really good. And it's right here in this room. And so I'm just going to take a couple of minutes because you all are very excited about hearing your colleagues' work and getting the opportunity to go around and sort of see all the work that's happening. But I want to just re-ground us in why we think this is such an important aspect of your education. Many of you came to UCSF really with a firm commitment that biomedical research was going to be in your DNA, so to speak. And so having to engage in a research type project or a scholarly project didn't seem all that foreign to you. Others of you may have come in with the idea that you were going to be a community-based pediatrician or a public health advocate. And so this idea about why do we need to spend so much time thinking about how we investigate problems and how we draw solutions and how we actually communicate them to others maybe felt a little bit more foreign in terms of the way you were considering your career. I spent most of my career as a practicing clinician, as an educator. I am not a biomedical scientist or a researcher. I've never had an NIH grant. And yet this was one of the most important parts of the curriculum for me as we began to design the Bridges curriculum. And it's because the inquiry, in my mind, is the real reason that doctors exist. The real reason that doctors exist is inquiry and curiosity. Now, that might seem a little stark to you, but think about this for a minute. Right now, every single bit of information that you are learning in medical school is available online. In fact, I suspect some of you have never actually opened a book about this information. It's all online. If it's online for you, it's online for your patients and for the communities. So what is our value as physicians if all the information that we use to make decisions is available to your patients as well? And people have asked that question. Of course, and there are people who are attempting to disrupt healthcare by sort of saying, we'll just make an app for that. Just plug in your symptoms and someone will give you a diagnosis and everything will be cool. But I really believe that the role of the physician in this era, in this digitally charged, technology adept, exploding scientific concepts era, is to be the person who can ask great questions, the person who recognizes when things aren't really hanging together, the person who takes that instinct that things aren't really hanging together, and instead of just saying, as Bob Nussbaum, a previous colleague of ours, said, one of the four most intellectually devastating words in medicine, or three, wait, the three most intellectually devastating words in medicine are when people say, we see this. We see this. And you might hear that as you travel through the clinical environments. You'll have a patient who's sick and has a finding no one can explain, and somebody at some point will just kind of shrug their shoulders and say, we see this. When you hear that question, that's an inquiry trigger. You should sort of say, well, if we see this, why? And what might I do, given my understanding of how to ask good questions in biomedical science and population health and education and engineering and psychology and sociology? How might I actually explore this and see if I can figure out why exactly do we see this? That's a critical question, and that marks the difference between a truly outstanding physician and one who actually is just kind of going through the motions. This makes a difference for our patients. I'll give you two examples. One, I just got off the phone talking to a colleague at the University of Cincinnati about his work. And then one I'm going to talk about from my own personal experience, where it makes a difference to ask the question. So this gentleman, Rob Kahn, is a pediatrician at the University of Cincinnati and Cincinnati Children's Hospital. He studies population health and pediatrics. And they asked the question, why do we have such a terrible epidemic of asthma in our patients in Cincinnati and that are being handled by this particular hospital? So they asked that question and then took a little deeper dive and they said, well, is it all patients that are having this asthma epidemic? No, it turns out it's just patients in a couple of zip codes. So that's kind of interesting. And then you sort of said to people, well, why do kids from this zip code seem to have so much asthma? And people sort of said, well, we see this. We've been seeing this for a while where, you know, it's probably a whole bunch of stuff. You know, it's they don't have good access to care. They don't have parents who help them be adherent to medications. Maybe there's more air pollution in that environment. So they took a deeper dive and they did something really curious. They began to geomap the neighborhoods these kids were in, even at a lower level than the zip code. And then they actually went to the law center at the University of Cincinnati and asked them to geomap suits about housing. And they overlaid those two maps. And from this, what they discovered was the vast majority of kids with refractory asthma and recurrent hospitalizations for asthma not only came from the same zip codes, but they actually lived in houses that were owned by the same landlord. And then they asked the next question, what do we know about this landlord? And they actually went further to other governmental agencies and found that this landlord is notorious for all sorts of criminal shenanigans and code breakage. And so the solution that these children need for their asthma is not another prescription for albuterol or another prednisone pulse or another education about how to use a spacer in inhaling. The solution for this is to actually work with the other people in the environment to get rid of the landlord who's causing these terrible illnesses. That's an inquiry result. And that came about because a physician was more curious than just shrugging their shoulders and sort of say, yes, kids from this racial and ethnic group who live in this neighborhood get sick all the time, we see this, I don't know what to do with it. That's what you can do with the work that you've been doing and the skills that you've been learning. So I'll close with an example close to home. I'm the oldest of 5. I'm the only doctor in my family. All of my siblings have had serious illnesses. And about a month ago, I had a call from my brother, who is about 3 years younger than me, blue-collar worker, heavy smoker, who talked about how he had terrible night sweats and had lost about 60 pounds, and his doctor was thinking about maybe working that up. So he said, well, yeah, that definitely needs to be worked up. That sounds like a problem. And of course, eventually gets a chest x-ray, and lo and behold, there's a big mass in the right upper lobe of his lung. And the doctor sort of says, well, you know, you're a heavy smoker, and this is most probably lung cancer, and we just need to keep moving on with this. And so they set him up for a bronchoscopy and decide to put him on some antibiotics. And lo and behold, on the antibiotics, the night sweats go away, he starts to feel better, and the mass actually is still very dense there, but the doctor keeps telling him, we think you have this lung cancer, we should get it worked up, which is, of course, reasonable. Well, it turns out, good news is, he did not have lung cancer. Good news is he has a lung abscess, and he has a lung abscess with a really newishly discovered organism called Staph lugdunensis, which is, again, an unusual bacteria, and it just precipitates another set of questions. The first set of questions arose when he called and told me I had these night sweats and fevers and weight loss, but now they put me on penicillin and it's gone. Do you still think that's compatible with lung cancer? And when you hear things like that, you have to train yourself to say, wait, what? Wait, that doesn't make sense with lung cancer. You cannot treat lung cancer with antibiotics. So if it's getting better, let's look a little bit deeper. And then the next point of inquiry is when you get back these weird biopsy results and sort of say, wait, what? Staph lugdunensis, who knows what that is? How do you get it? And what needs to be done for this patient now? So these are just 2 examples, one at a very high population level, one at a deeply personal level. He's getting better now, which is so exciting. Some of those children are getting better in Cincinnati. Unfortunately, not all of them can be turned around very quickly. But the reason we think inquiry is so important is because it's vitally important to your value as a physician. You can all be, based on the skills you're learning in the inquiry curriculum and the work you've done, the type of people who don't just say, we see this and move on, but you say, we see this, let's figure out what it is. Because in figuring out what it is, we can make the world better, not just for this patient, but for future patients. So with that, I'm going to thank you again for all the effort you put into this. The amount of work here is simply stunning, and I know that many of these projects are going to go on to change care and change the way we look at different social systems, and I hope that you'll look back on this phase of your career with great pride and excitement for the skills you learned under the leadership of Dr. Redberg and her colleagues. So with that, stop there. Thank you.